गलत से कहीं नहीं, हम तो बस ये कह रहे हैं कि लोग डालने वगैरह में आते हैं। So, can we have the then if Dr. Veera can join later and Dr. Likhita can initiate the proceedings?
Okay, sure. I think we were waiting for Dr. Veera Raghavan to join. Well, good evening, everybody, and welcome to the second of the National Neonatology Forum Journal Clubs. This was a new activity which we had started last month under the auspices of the National Neonatology Forum, and with very active and vibrant inputs from both the NNF secretary and the NNF president. The first journal club was a huge success, and we decided to carry it on further. So the reason why we started this NNF journal club was that we now have a large number of students who are DM, DNB, DRNB students. They are fellows of NNF and IAP centers, and not all of them have access to a high level discussion on latest research and research articles that are being published. And we thought it would be a good idea to have a monthly forum where everybody who's interested in appraising the recent literature gets an opportunity to interact with experts and to listen to recently published articles and their critical appraisals. So today we have uh, the host institute, which is Ankura Hospital in Hyderabad, which is going to be presenting a paper. The faculty member from the host institution is Dr. Veera Raghavan Ramaswamy. He is a DM, DNB from LHMC Delhi. He was a neonatal trainee in Oslo, Norway, and a clinical fellow in Oxford. And he's currently the consultant neonatologist and head of the Department of Neonatology at Ankura Hospital for Women and Children in Hyderabad. As many of you may be knowing, he's also a task force member of the ILCOR, which makes recommendations about neonatal resuscitation. And he's a member of the Cochrane Neonatal Editorial Board. So he's a very accomplished person. As our external expert, we have none other than Professor S. Mangalabharati. He is a professor of neonatology at the Department of Neonatology in Madras Medical College, Chennai, and the head of the Center of Excellence for Newborn, IOG, Chennai. He's also consultant neonatologist at the Mehta Children's Hospital in Chennai. And he is a very accomplished researcher. He's site PI of many national and international multicentric trials. He is interested in placental transfusion, medical devices, perinatal transfusion, and is an avid teacher and researcher. So with that, I don't see Dr. Veera Raghavan having joined yet. So what I'll do is I will straight away request his student, Dr. Likhita Verma, to start presenting this paper. Over to you, Likhita.
Yes, sir.
You can share your slides.
Sir, are my slides visible, sir?
Yes, they are visible and you're audible. Likhita is a DRNB neonatology student, as you can see, under Dr. Veera Raghavan. Go ahead, you can start presenting.
Yes, sir. My slides are moving, sir.
Yes, your slides are moving. Please start.
Good evening, respected faculty and dear colleagues. Myself, Dr. Likhita. Let's go into the presentation. During the course of this presentation, let's go through the introduction, few evidences, and the journal per se in detail. Respiratory distress syndrome is the most common disease in preterm infants, and it is caused by insufficient surfactant production during early gestation. So advances in neonatal medicine have brought new approaches for surfactant administration, moving beyond traditional method of surfactant administration, followed by continued invasive mechanical ventilation. Few newer modalities like INSURE, that is intubate, surfactant, and extubate. Another is LISA, that is less invasive surfactant administration. Next is SALSA, that is surfactant through laryngeal or supraglottic airway. Next is INREXURE, intubate, recruit, surfactant, and extubation. These modalities have shown to reduce respiratory morbidities. According to NNF Clinical Practice Guidelines 2021, LISA may be preferred over INSURE for surfactant administration in preterm neonates less than 34 weeks gestation with respiratory distress syndrome. It is a weak recommendation with moderate certainty of evidence. This is a great summary of finding table comparing LISA versus INSURE in preterm neonates with respiratory distress syndrome. LISA is associated with lower rates of bronchopulmonary dysplasia, mortality, need for mechanical ventilation, pneumothorax. Even 4 years back, when literature was reviewed, there was 12 RCTs that has compared efficacy of LISA to INSURE, and certainty of evidence for most of the outcomes was moderate. Now that we have the background, let's begin today's journal club presentation, that is a national cohort study done in Korea on neonatal outcomes of the INSURE versus LISA method for surfactant administration. Aim of the study is to compare the efficacy between INSURE and LISA methods in very preterm infants with respiratory distress syndrome. Methodology: the study population is preterm infants born before 32 weeks of gestation who were diagnosed with respiratory distress syndrome and received alternative surfactant replacement therapy, that is INSURE or LISA method. It is a retrospective analysis of prospectively collected data, that is retrospective cohort study. Time frame is from January 1st, 2019 to December 31st, 2022. Inclusion criteria is less than 32 weeks of gestational age neonates with respiratory distress syndrome were included. Neonates with chromosomal abnormalities and congenital disorders were excluded. This flowchart outlines the patient selection process used in the study. Total of 7,838 preterm infants were included from Korean Neonatal Network database between 2019 to 2022. Of these, 203 neonates were excluded due to chromosomal anomalies and congenital disorders. 5,667 were diagnosed with respiratory distress syndrome after excluding 209 infants who did not receive surfactant and 208 infants more than or equal to 32 weeks gestation. So 5,250 infants were under surfactant replacement therapy. Among these, 4,138 infants received trial of intratracheal method. So finally, 627 infants were in the INSURE group and 485 infants were in the LISA group. These are the outcomes studied and with their definitions. Statistical analysis. All statistical analysis were performed using IBM SPSS statistics for Windows version 20, IBM Corporation, headquarters Armonk, New York, USA. Differences between the categorical variables were analyzed using the chi-square test. Continuous variables were tested using an independent t-test. Receiver operating characteristic curves were used to determine the cutoff values for non-normally distributed continuous variables. A multivariate logistic regression analysis was used to compare the two surfactant administration methods. Statistical significance was set at p-value of less than 0.05. Protocol registration was not done. Ethical approval was obtained from the institutional review boards of Korea University Annam Hospital. This table shows the baseline characteristic on patients in LISA versus INSURE. LISA group had a lower mean gestational age, lower birth weight, smaller proportion of mothers with diabetes mellitus, which are the potential confounders. Therefore, these should be kept in mind when interpreting the clinical outcomes, as they may influence respiratory prognosis and treatment effects. This table shows the major morbidities and complications in infants receiving surfactant via INSURE versus LISA. LISA group has shown to be associated with lesser odds of bronchopulmonary dysplasia, composite outcome of bronchopulmonary dysplasia or death, massive pulmonary hemorrhage, PDA requiring treatment, and culture-proven sepsis. Here it is to be noted that the absolute risk difference of these outcomes between two groups were trivial to small. Limitations of the study as said by author. Unclear classification of the INSURE failures. It remains unclear whether the INSURE failures requiring invasive mechanical ventilation were categorized as intratracheal method, because this is a potential misclassification which could explain a higher number of excluded cases. Next is a missing data in the registry. Data on repeated surfactant administration, ventilator modes, and timing of mechanical ventilation is missed. Unequal group sizes. And there is no distinction in sepsis onset or analysis of center-specific effects. Technique variance in LISA between the units. Few units use OG tube, orogastric tube with Megel's forceps, which may be technically more difficult than the thin catheter. Next, unmatched timeframes in the LISA adoption. During the starting of study, mostly INSURE was used. There is increased adoption of LISA over time, and it is a potential temporal confounding factor. There is a paucity on acute surfactant replacement therapy side effect data, like surfactant reflux, desaturation, bradycardia, or need of positive pressure ventilation. There are lack of standardized protocol across the Korean neonatal units for sedation, oxygen supplementation, and ventilation of surfactant administration. Other limitations include appropriate for gestational age, small for gestational age, and intrauterine growth restriction details were not provided between the groups. Type of surfactant, timing of surfactant, and type of primary respiratory support details were not available. Delivery room CPAP and admission temperature details were also not available. Author's conclusion. Although LISA did not demonstrate a reduction in either the requirement for respiratory support or its duration compared to INSURE method, it was associated with decrease in severe bronchopulmonary dysplasia, severe bronchopulmonary dysplasia or death composite outcome, pulmonary hemorrhage, patent ductus arteriosus requiring treatment, and sepsis in a Korean national cohort. These findings suggest that LISA provides substantial advantages for mitigating several forms of neonatal morbidities and remain an appropriate choice for surfactant delivery in spontaneously breathing preterm infants with respiratory distress syndrome. This is a stroke checklist that is strengthening the reporting of observational studies in epidemiology. It is a 22 number checklist. Here in objectives, whether the given journal stated specific objectives including any hypothesis. No, it didn't. In the participants, for matched studies, give matching criteria and number of exposed and unexposed. No, it was not clear. In the bias, did the study describe any errors to address potential source of bias? No, it was not. In the statistical methods, describe any methods used to examine subgroup and interactions? No. And explain how missing data were addressed? No, it didn't address. If applicable, explain how loss to follow-up was addressed? No, it was not addressed. Describe any sensitivity analysis? No, it did not describe any sensitivity analysis. Give characteristics of study participants, demographic, clinical, and social, and information on exposure and potential confounders. It was not clear. In the descriptive data, indicate number of participants with missing data for each variable of interest. No, it was not clear. In the main results, give unadjusted estimates and if applicable, confounder adjusted estimates and their precision. Example, 95% confidence interval. Make clear which confounders were adjusted for and why they were included. Only few confounders like gestational age, birth weight, maternal diabetes mellitus were the confounders which were adjusted. If relevant, consider translating estimates of relative risk into absolute risk for a meaningful time period. No, it did not. Other analysis. Report other analysis done. Example, analysis of subgroups and interactions and sensitivity analysis. No, it was not done. In the limitation, discuss limitations of the study, taking into account sources of potential bias or imprecision. Discuss both direction and magnitude of any potential bias. It was not clearly mentioned. Generalizability. Discuss the generalizability, external validity of the study results. It may be. It is not clear. With this, I would like to conclude. Thank you.
Thank you very much, Dr. Likhita, for that very nice presentation.
Thank you, sir.
As I still can't see Dr. Veera having joined, I'm going to hand over to Dr. Mangala Bharti, who is the external expert, who is going to have some teaching points about this paper. Dr. Mangala, in case, before you share your own slides, in case there is some slide you want to go back to in Likhita's presentation, if you want to illustrate something, say with the main outcomes or something, you're welcome to do so before you start sharing your own slides.
Okay, sir. Likita, just let your slides be there. I'll just give a. I think she has stopped sharing. Okay, no problem. We can go back if necessary. Yeah, thank you. I think as we have first of all, congratulations, Litika, for a wonderful presentation. You have nicely presented the various subtopics of the journal. And also you had used the standard stroke toolkit for critically appraising this article. I believe that the students who are here would have gone through this article. So because the discussions, you will be able to relate and understand more if you had gone through the article earlier. For those, if we have not gone through, I'll just quickly summarize the major things about this article. So this article is from Korea, and it is from a database, nationwide database, where they keep collecting data of their neonates from various NICUs. From the data available in that database, they had done an analysis comparing two kinds of surfactant administrations in babies who are less than 32 weeks of gestation. So they had compared Ensure technique against the LISA, less invasive surfactant administration. And they have tried to find out whether there are any differences in clinically relevant outcomes like death, BPD, combined outcomes of death or BPD, and other outcomes like PDA, sepsis, and all those things. Litika, can you just show me the two tables alone? Can we go to the first table? Just the baseline characteristics table. Yeah, thank you. Yeah, just stay with this baseline characteristics table. Yeah. So this is, we do see that actually of the two groups, there are some statistically significant differences in some major factors. Like, for example, if you look into the gestational age, so looks like the LISA group was much younger, at least by around 1 to 2 weeks of gestation compared to that of the babies who are there in the Ensure group. That is getting reflected in the birth weight also. They were smaller in birth weight. when analyzed through a p-value, the value had turned out to be significant. And there is also a difference in terms of maternal diabetes mellitus. Lithi had pointed out that. In an observational trial, it is quite likely that we end up in such a scenario. Like there will be a differences in the baseline characteristics. So what they have done, can you just move to the next slide? The results, outcomes. Next slide, please. Yeah. So you do see that they have presented various outcomes, BPD, whatever is there left as the outcome. You just see there are two groups. They have given the percentage of each outcome in the Ensure group and the LISA group. And the third column, what you see is AOR. I think all of you know what is an AOR. AOR is an adjusted odds ratio. So what do you mean by an adjusted odds ratio? So they had calculated an initial odds ratio comparing these two groups. But as there are differences in baseline characteristics in some of them, which had shown to be statistically significant, they had tried using a statistical method of regression of adjusting for these variables and then coming out with an odds ratio called as an adjusted odds ratio. So that is what they had shown here. That adjusted odds ratio has been different for some parameters like severe BPD, massive pulmonary hemorrhage, and PDA, and it is not statistically different for the other outcomes. So in a nutshell, this is what the article is all about. I'll just touch upon a few points related mainly to the statistical methods. I'll share my slides. Can you just stop sharing, Litika? Yeah. Sir, are my slides visible, sir?
Yes, they are visible.
Yes, fine, sir. So I think for the beginners, I know that most of you here are very in advanced level in research methodology. But see, I think some of you might wonder, okay, so is it not an interventional trial? So Ensure is an intervention and LISA is an intervention. There are two interventions done here. And why are we calling this trial as an observational study? I think it's pretty obvious. The most important factor that differentiates an interventional trial and an observational studies, especially when both are about comparing intervention, is that has the researcher formed the groups based upon the intervention. If it is an interventional trial, so we plan it that there are going to be two groups. Group 1 is going to receive intervention like an Ensure, and Group B is going to receive an intervention like LISA. So the researcher plans all these things. He forms the groups based upon the intervention. That is the typical design of an intervention study. So what is an observational study here? So the researcher has not done anything. We have not done anything to form the groups. The clinicians themselves, they have used Ensure for some patients based on their own decision. And some babies had received LISA. And now the researcher goes and just try to take the data and try to classify this data based upon what intervention has been done. So that is why here we don't use the word intervention in general statistically. That we all know the term. What we use is we call this as an exposure and an outcome, because the intervention was done in nature. The researcher has not decided that. So the exposure, there are two exposures we are comparing here, the Ensure versus LISA, and there we are measuring various outcomes. In the last journal club, so there was a lot of discussion. We learned a lot about a randomized control trial, which is sitting at the top pinnacle as far as the quality or validity of the various study designs are concerned. But now we are focusing on these observational study designs. So people might be wondering, can we still do observational studies, especially when you're talking about interventions like this? Observational studies have their own strengths. I'd like to point out a few important strengths of observational studies. Number one, you just look into actually the volume that we can have access to. So this is a national database from Korea, which has access to thousands and thousands of babies. if you are going to plan an interventional trial, it will take years and years for you to have thousands of babies, or you may have to do put in a lot of resources to conduct a multicentric study and all. So it is in observational trials, we get quick access to a huge volume of data, especially if the data is already available, like a data is in a registry. That's number one, which is a big advantage of observational studies. The second one, unlike randomized controlled trials or interventional trials, which are very experimental in nature, which are very controlled trials, these trials actually, to some extent, reflect what happens in the real world. Like just clinicians, some clinicians chose Ensure and some clinicians chose Lisa. It was not a very controlled environment and all. So this advantage, what happens in the real world, we get useful information from observational studies. This is an advantage compared to that of controlled interventional trials. Of course, we know that observational studies are more prone for bias, but if there is a good registry with audited or quality assured data capturing mechanism, and then we can very well avoid this bias called as a recall bias. The last one, so this is a scenario where still you can do an RCT. We can compare Ensure versus Lisa, but it may not be practically possible or ethically correct to compare some interventions. In those scenarios, either you don't have the resources or it is not feasible in your setting, or ethically also it's very challenging. It is not ethically correct to compare some interventions. Then we fall back to observation studies. So these are the major strengths. Having talked about the strengths, we should be aware of the major weaknesses of observational trials. The first and foremost, you would have looked into the conclusion what the authors have made. That is a little worrisome. See, observational studies can only talk about association between an exposure and an outcome. They can never conclude saying that the exposure resulted in an outcome. Why so? Obviously, that's the second point. Observational studies are more prone for a lot of variable types of biases. And the most important thing is the confounding bias. Because we just saw the table, right? There are lots of differences between the two groups. They're not comparable by even known confounders like gestational age, birth weight, maternal morbidities. When they are not at all comparable as a baseline, all these factors become confounders. Of course, there will be a lot of unmeasured or unknown confounders again. So these are all the confounding bias is a very big problem in observation studies. That's why we always say, you talk about an association, you can say whether there is a strong association or a weak association, but we cannot go on to say the exposure resulted in outcome. It cannot give causality. Causality has to be shown only in an interventional studies. And we saw some adjustments. We talked about an adjusted odds ratio, but still, as I pointed out earlier, adjustments can be done only for known confounders, right? There could be a lot of unknown confounders or unmeasured confounders. So there will be a lot of residual confounding even after statistically adjusting for these variables. And the other two important biases are selection bias. So what do you mean by selection bias? Whenever a baby comes in an interventional trial, that baby has an equal chance of going into one of the two in a random randomized control trial. But here, there was no fixed criteria, right? Based upon various criteria. So maybe people could have picked like more stable babies for doing ELISA. And when a baby was a little bit sick, clinicians might have thought it's better to intubate and give it through Ensure. So they have not picked up the same kind of babies with same level of sickness or same level of gestational age, comparable level. So that is what we call as a selection bias. So that is a very observation studies are more prone for selection bias. And there is also a risk of what we call as a misclassification bias. I'll touch upon it. It's coming in the further slides. I'll explain with example that you can understand. So just to repeat, the major biases in observation studies, selection bias, as it is decided by the clinician, the treatment preference of individuals. It's not comparable between the two groups. There are a lot of confounders, both known and unmeasured. So what do we mean by misclassification bias? So whatever we define as an exposure has to have a criteria which is applicable across both the groups, like presence or absence. Sometimes it is difficult. There is an example here in this study. I'll show you in the next slides. We'll come to misclassification bias. What is measurement bias? So this is from a database, right? The data, whatever data is being captured in the database, that data only is accessible to us. Some important data you think is very relevant to this intervention. If it is not there in the database, obviously there is no way we can have access to this data. There will be a lot of incomplete data that brings in a bias called measurement bias. Okay, so in general, these are used mainly when we have a good database available, a good quality data, huge data is available, or when it is ethically or resources wise, it is not feasible to do an RCT, we settle for observational trials. Or if you are going to study very rare exposures or outcomes, again, we have to put in a lot of resources. Their observational trials are more handy. And when you want to know really what is happening in the real world, even though there is some data from RCTs, this observational studies are really useful. So I'll just touch upon only whatever we have discussed in the index article. I'll take only 2 or 3 minutes and then I'll finish. See the advantages, a huge national cohort, more than 1,000 babies. From a very good prospective registry, with they have defined, they have shown the various standard definition they have used for the various measurements. And they had adjusted for the differences in the baseline variables like gestational age, birth weight, maternal diabetes mellitus, repeat dosing of surfactant and things like that. And they had a very good diagram showing transparently who were included and who were excluded. A fantastic transparent flow diagram. These are big strengths of this trial statistically. But it is definitely, it's a non-random allocation. People would use different criteria for Ensure and LISA. And what do we mean by residual confounding? In the previous slide, we saw that adjustments were done for these variables. But what about, for example, what about different NICUs? You can't expect the same clinical level of management or resources in all the NICUs, right? Different NICUs will have different outcomes. So this is a big confounding factor. That factor still remains. It has not been adjusted here. And I said I'll talk about classification, misclassification bias a bit. So there is a misclassification bias here. What is it? They had actually 3 categories for people who had received surfactant. They said one is by intubation. The second they called Ensure. The third they called LISA. What do you mean by, I assume that whenever there is no rapid extubation and baby continued on a mechanical ventilation, they have not classified it as Ensure. But it's quite possible, and they have not used, as far as my knowledge goes, and from the paper, I cannot understand whether they have used a fixed timeline, like if the extubation happens within, say, 2 hours, 1 hour, then we call it as Ensure. Otherwise, we'll be calling it as an other method. That is not there. So there is a lot of overlap. Some cases who really were Ensure could have gone into the other group. The reverse is also true, like those who have failed Ensure would have got intubated. And those babies also from the database, they would not have been labeled as Ensure. This is what we call as a misclassification bias here. And they had shown an adjusted odds ratio, but in any study, we expect them to first show the crude odds ratio, because that is the truth, right? The real one, even though there are differences. We would like to know what was the difference between the 2 groups in terms of the real crude odds ratio. Then let them show the adjusted odds ratio so that the reader can understand how the odds ratio changes, presence or absence of certain factors. If that is missing, I consider that as a statistical weakness of this paper. These all we have already discussed, the various biases in this one. The last one we'll touch upon, which measurement bias. So what is the measurement bias in this article? What about the adverse events of LISA or Ensure? Is it leading to more bradycardia, apneic episodes? That is an important parameter. We are looking only into the benefits, right? There are risks associated with the procedure. There is no data on that. Look, because there is no data in the database. But that brings in a bias called as a measurement bias. So to conclude, there's a large data set with good external validity, clear objectives and reporting. Outcome definitions are reasonably good. They have done an adjusted logistic repression. They're all done well. But I feel they could have reported a crude odds ratio. They have mentioned the sample size later somewhere in the discussion. It would have been better if they had shown a priori sample size clearly, and for what outcomes they have calculated a sample size, because they have done multiple analysis. We don't know how good was the sample for doing those repeated. Whether they corrected it for that repeat analysis, we don't know. And the third is a little more technical parameter. Only this people who have read the paper in detail, they would have understood. One important measurement like duration of ventilation. It was converted into from a continuous variable for analysis, it was converted into a categorical. They did some ROC and they choose arbitrary days like 2 days and 7 days. Fine. They had some statistical difficulties where it is difficult to do adjustments if you keep it, but it loses its granularity. It's always better if you keep the raw data as continuous and analyze that. They could have attempted. Adjustments for the various NACUs could have been done. What do they mean by ensure could have been better defined? So that could have been done better. So my take home, observation studies are very, very valuable for understanding the scale and the trends, but they can never give you causality. And always, whenever you are looking at an observational trial, look for these 3 important biases: selection bias, confounding bias, and misclassification bias. There could be some measurement bias as well. And yeah, so they are very good for descriptive surveillance and hypothesis testing, but not, they can't give you causality proof. Sir, I will stop here and hand it over to you, Sir Saurabh, sir.
Thank you very much, Dr. Mangala Bharti, for that superb, exposition on observational studies. I'm sure all the students would have learned a lot of new concepts from this. We are lucky that Dr. Veera Raghavan has now been able to join. I think he had some technical difficulties with joining earlier. And I would request him to cover the aspect of how is this applicable, the results of the study applicable to our Indian NICUs? What is the generalizability like in his own setup, which is in the private sector, and in ICUs of like his own within the Indian scenario? Over to you, Dr. Veera.
Thank you, sir. I'm quite sorry. I was in another meeting. I just joined in. Coming to the point of generalizability, we have to think about 2 things: transportability and generalizability. So this is a study that is done in in South Korea, Seoul, I guess. So they have a strong database. In India, do we have? I'm not sure we did have, but over a period of time, judgment I can't make, but still, yes. We don't have a strong database. That's what I infer from whatever knowledge I have. So from the study design aspect, this generalizability aspect may not be applicable. Then coming to the population, the newborns who were involved, yes, of course, they were all less than 28 weeks. We do care babies who are born at less than 28 weeks, even in public sector and private sector hospitals. It's fine. Intervention comparator, Lisa and Ensure, we are all quite competent in doing so. Outcomes, yes. Now, what is transportability? That is a new concept, right, sir? So generalizability is when the South Koreans are talking about adapting the findings of the research from their trial to parts of South Korea. Now we are talking about adapting the findings of this particular cohort study to India. That's transportability. So that's both of them are quite different. So as far as generalizability is concerned, yes, it's generalizable to South Korean population, and to our population, as far as transportability is concerned, I am quite uncertain. And one more aspect that I wanted to dwell upon was this study actually required? which I had a discussion with Mangal Bharti sir. When you had so many RCTs on less invasive surfactant administration through various ways versus insure, what is the point of having an observation trial? How does it fare in the process of grade? What does grade recommend when we have ample number of RCTs and you have evidence from observational trials? That's a question that sir, you can answer or anyone can develop on.
Okay, thank you, Dr. Veera. I hand it back to Dr. Mangala Bharti. There are questions that are there in the question and answer chat box, and maybe
I
you could
had one-
take these. Yeah, please, Dr. Amit, please go ahead.
Regarding generalizability, so can I use this study in my unit and think of, okay, do I use Ensure or do I use Lisa for the next baby, preterm baby who is on CPAP with who requires surfactant? So I was not sure what was the conclusion of Dr. Veera Raghavan about generalizability. But I see no reason why the results of that study would not be applicable to my babies in the range of above 26 weeker, because below that, the population could be different. But so how do we assess generalizability to or external validity of a study? That is the question which we have. So I presume I was thinking before you asked that question. So I was thinking, yes, it should be generalizable to me, though things like having the Lisa catheter, that could be a factor which could be a problem, but Ensure is easily doable. Other thing was ensure how long do we put in the tube and continue ventilation before we take off the tube. That is very, that was not mentioned exactly, though duration of ventilation was mentioned, but duration of Ensure before extubation was not mentioned. So that was another thing which came to my mind. How do I generalize that? Do we just continue? What we do is we do it for about 5 to 10 minutes, assess FiO2s, assess chest movement, and then we decide whether to continue for about half an hour or we just remove it right away. So I would like to have more experts' opinion about generalizability of this study and the use of Ensure and Lisa in our settings in India.
Dr. Mangala Bharti, I'll just answer only this bit, and after that,
Yes, sir.
you can also give your bit and then take up all the questions that have come in the Q&A from the students. And I would encourage the students to put in more questions in the question and answer chat box. We really would love to take up your doubts. So regarding generalizability, what I learned was from a professor of clinical epidemiology at the University College of London, Professor Ruth Gilbert, who had once told me that, look, if you are expecting that babies enrolled in somebody else's trial are going to be carbon copies of your own, of the babies that you handle, and that you will use, the conclusions of another study only if your babies are absolutely identical to them, you will never find such trials, right? Because there are going to be differences all over the world. So as long as you have the infrastructure and the drugs, or whatever you're going to use, which is similar to what has been described in the trial, your question should actually be framed more positively. And that is, are my babies so different from the ones in the trial that I cannot use the conclusions that they have drawn in that trial? Rather than, putting it negatively that, well, our babies are different in this, this, and this, therefore I cannot use the results of the trial. So I think the way we should go about it is, are our babies so different from the ones reported in the study that we cannot use their conclusions? Provided, of course, we have the Lisa catheter, we have people who have the capability to, perform the procedure. Assuming that those things are all there, that is the question that we should ask. And as I think, as Amit said, that there is really no reason for not being able to use the data from this study into our own setting. Over to you, Dr. Mangalavarthi.
Yes, sir, just a quick sub question of just what you had discussed, sir. So obviously in observational trials, as the numbers are huge, the generalizability and external validity should be much better from observational trials when we have access to a huge number of infants compared to smaller interventional trials. But the concern is about internal validity. On one side, we have RCTs where the internal validity is so good, but the numbers are much less. On the other hand, we have observation trials where there is a questionable internal validity, but the numbers are huge. So how do we take a balance when we interpret?
Yeah, I would say that, once the point has been proven by randomized control trials and systematic reviews of randomized control trials, then your huge observational study like this is almost working like a phase 4 trial. It's equivalent to that.
Yes.
It's like a phase 4 trial. That means like once that even, companies that launch new drugs do, once it is launched into the market, you're still following up
Surveillance.
and collecting results, right? You don't say that, oh, I've conducted so many randomized control trials, so my job is done. It's not done. Like there are so many examples in medical history where new finding came up in a phase 4 analysis of the data. So that's how I would take it.
Thank you, sir. I'll just start with some questions which may be very relevant for the students. Lithika, can you answer a simple question? Somebody had asked, it looks like the data was
I
from
think the
the
first question is sample size calculation in the
sir,
question
one by one.
Q&A chat box.
Yes, sir. I thought, shall I just prioritize certain questions which may be more, or shall we go on?
Yeah, sure.
I thought we'll just.
I thought maybe I'd missed it.
Yes, sir. I'll include all the questions, sir. Lithika, can you just take up this question? Somebody had asked actually, is it a real prospective cohort? It looks like the data was from the past and they had collected the data from a database. So is it appropriate to call this as a prospective cohort? So that is a question from Priyadarshini. The author says it's a prospective cohort. So can you take up this question?
Sir, as the data is taken from Korean Neonatal Network database, I think they collected the data, but it was retrospectively assessed. So I think it is retrospective cohort study. Prospectively collected retrospective cohort studies.
Okay, so this is you are sure this is a retrospective cohort, right? Or are you not sure?
Yes, sir.
Sorry, you're sounding a little bit not sure about it. So obviously the study had been done in this year, 2025 published. Maybe they could have analyzed in 2024. They themselves had done this data is from 2010 onwards. So from a database. So this is a retrospective cohort. They have not used that word retrospective cohort in the study design. So it would have been better if they had mentioned the study design as a retrospective cohort study. That is again, I'll say something which could have been improved upon in the write-up. This is a retrospective cohort study only. Shall we move to the next question? Kvira, can you take this up? In a critical appraisal, so which is better, STROBE or CASP for observational studies? This is again from Priyadarshini.
Thank you, sir. So for appraisal, I will say there are two aspects. One is the reporting standards like STROBE. The other one is assessing the risk of bias in the study, which I would actually be interested in. Like this is a study of interventions, observation study of interventions. So I would preferably use Robinson risk of bias in non-randomized studies of interventions. And then I would come to a conclusion whether this study is at a risk of say a low, moderate, serious, or a critical risk of bias. So there are two aspects: reporting, that is from the author's aspect, and from the person who is actually judging the study regarding the risk of bias. That is where we use the tool like Robinson for this aspect. For interventional trials. You have Robin C for trials for exposures. You have ROB2 for R6 and so on and so forth.
Yeah, thank you, Veera. I think the answer that Veera is given is excellent. All tools are good. They are more or less, they look into the various aspects of study design. It's only the purpose for which we are applying. There's nothing like one tool is the best tool. So sometimes as clinicians, we just want to quickly look into a paper to see how good is the paper. Sometimes you look from the perspective of a researcher when you are doing, including that study in a meta-analysis or doing evaluating the quality of a paper, then maybe you will need some different kind of tool. So the purpose decides the tool. You don't need to worry too much about whether X tool is better than Y. All are good review tools only. So I think Lakshmi had asked a question about blinding. I think I'll just quickly answer and then Mosi. So this is an observational study, right? So the question of blinding doesn't arise here. Only when we are
Dr. Mangala, I don't think everybody is being able to see all the questions. So maybe you can read out the whole question.
Yes,
What
sorry.
was her question exactly?
Yes, sir.
So that everybody is on the same page.
Okay, sir.
And there are a lot of questions in the Q&A box.
Okay, sir. I'll just go one by one then, sir.
Yeah, I think
So it
go
will be
on
easy,
because
sir.
everyone would like to have their question
Fine, sir.
answered. Yeah.
Yes, sir. I'll go one by one. So Lakshmi Venugopalan has asked this question. Sample calculation was not mentioned. Is it allowed in retrospective cohort study? Litika or Veera, would you like to answer this? Why sample
Maybe
size
you can
not-
take it up yourself.
Yes, sir.
Yeah.
See, any study, whatever be the study design, definitely all studies require sample size calculations. So it's always when we are doing interventional trials, obviously, so we start with calculation saying how many numbers will we need in this group or that group because it is going to happen later in any prospective trial for that matter. When data is taken out of a database here, so there are two ways of doing it. One, obviously, you do a sample size calculation at the beginning to see that, to analyze uh, these two groups for a given outcome. You know, there are various parameters we use, right? What is the effect size that I'm interested in? So what is the errors alpha and beta that I'm willing to accept? What kind of parameter is that variable is there? So after including all these things, by doing a sample size calculation, I will get a number. I need these many babies in these two groups. So what they have done in this trial is that they have just taken all the data available from the database in a given period, but they have looked at whether this data is good enough for, they did their power calculations later, that is mentioned in the discussion. So it has been done. They have shown that whatever numbers they had is good enough for analyzing the outcomes of interest. But it was, the writing could have been better. They could have had a separate section like a sample size calculation, and it could have been very clear to the viewer whether their sample was good enough. They have addressed it in the discussion part. Sir, would you like to add more, sir? This or
Just a very small point. I agree with you.
yes,
Is
sir.
that sometimes what happens is that if you use these very large databases which have tens of thousands of patients, some even very trivial differences which are of no clinical significance, they also turn up to be statistically significant just because your n is very large. So you'll get a p which is significant, whereas actually it is of no clinical significance. So that is one danger, that just because you found something of statistical significance doesn't necessarily mean it's of clinical significance. So the problem is the opposite of what you may have in an RCT. In an RCT, you're struggling to have a sample size. Sometimes in these large databases, there is too big a sample size. So that becomes a problem. So a sample size calculation is always a good idea.
Yes. And Lakshmi had asked another question. As the data was collected prospectively, so sample we have addressed, she says she has asked proper blinding could have improved the study outcome. Litika, can you take up this question? Could they have done a proper blinding to improve the study outcome in this study?
No, sir.
Okay.
Yeah.
Veera, please step in. Yeah, Veera can step in. Yeah.
Yeah, it's a good question. See, so your question relates to not Straub, but Robinson, as Mangala sir told. Can look at it in this way or that way, whether you are assessing the reporting of the trial or whether you are a clinical methodologist who is doing a meta-analysis and trying to assess the risk of bias in this trial. So for blinding, you have a flow chart in Robinson. It's quite easy to follow the flow chart. And which outcome are you interested in? That is the most important thing. If the outcome is an objective outcome, then blinding might not have a major say. If it is a subjective outcome like neurodevelopment assessed by say Bailey scale or something like that, then that might have a major bearing. So yeah, that's how it is. Yeah, go through Robin's. I hope we'll have sessions on that as well in the future. Thanks for the question. It's an important question. Thank you. Are we online?
I'm sorry. Yeah. I think, yeah. Am I audible now?
Yes, sir. Yes, sir.
Yeah.
Was my, I mean, explanatory answer
Yeah.
audible and
Yeah. So maybe for just for the students, see, when we talk about blinding, you know that actually we don't use no more. We use those terms. No, it's not preferred to use single, double, or triple. We need to know. So whether it's all about mainly about intervention. Like Lisa, in this paper, it is about Lisa and Ensure. When we say if people who had administered the intervention didn't know whether they are doing Lisa or Ensure, was it possible? Or the people who were around, or here newborns obviously are not, they are always blinded. But the people around who can measure the outcome, who are obviously the other doctors would have measured the outcome, right? Who had measured BPD, who had measured the other parameters like PD and all. Those who are in part of measuring the outcome, whether they were really blinded to what was the intervention, whether then. The third component is the person who is doing the statistical analysis. In the observational studies, the only thing like you may just give two groups without telling a person who is analyzing the data which is coming from what group. Otherwise, it is not possible. No, all these had happened earlier. The choice was the clinician's choice. People would have known what was the intervention. So it doesn't apply here as far as blinding is concerned. We'll move ahead to other questions. Despite higher repeat surfactant admission rate, this is from Ashok Garg. Despite higher repeat surfactant administration rate in the Lisa group, you reported better morbidity outcome. Why is it so? Yeah, that's actually a very interesting question. So there have been more need of a surfactant in the Lisa, but we are seeing the BPD, severe BPD rates are much less. So this could be an important confounder. So they have treated in this paper as an repeat surfactant administration as a confounder on the outcome of major outcome like severe BPD. They have done an adjustment for this repeat surfactant doses, which was more in the Lisa group. And they have still shown after adjusting for this parameter, the morbidity is much better in the Lisa group. So that is the way that they have looked into. You are right. We can take even a need for repeat dose of surfactant as an outcome also. If you take that outcome, then obviously it is more in Lisa. If you take BPD as an outcome, it is less. But in general, we look for hard outcomes, right, which are more clinically relevant. So let's say a baby received more dose of surfactant. So what? But if there is a more BPD, that is more worrisome, right? This is what we call a soft outcome and a hard outcome. So we give more importance to hard outcomes, and they have done adjustments for here. So I still, this is quite possible still. It is acceptable. Sir, shall we move on, sir, to other questions? How to do this is again from Ramya. How to do adjustments for confounding factors? Is it something done statistically? Till what extent should we learn statistics as a clinician? So we are living in a world which is an evidence-based, we're all practitioners of evidence-based medicine. So we all need to have, I think NMC mandates us, even from undergraduate level now, to have exposure and training in statistics. It is no more optional, it is mandatory. And at our level, DM or DNB level, we need to have very good training on statistics. This journal club is one such intervention or initiative from NNF in that direction. Coming to adjustment for confounding factors, so they have done logistic regression. So whatever the individual parameters that have been found to be different between the two groups in the baseline, and they have just included all those factors and then try to find out what is the change to the odds ratio once they modify for that factors. So I think for sake of simplicity, I'm just giving the name. Usually we use the regression methods for adjustment for confounding factors that had been done in this paper as well. Role of ROC, I think don't get confused. So this is not a diagnostic test. So here actually they have used an ROC. I was also a bit surprised, bit curious initially to see an ROC here. They had an outcome called, they measured the duration of ventilation, which is a continuous outcome between the two groups. They want to compare it between the two groups. Unfortunately, that it became a very it was not normally distributed. It was a skewed variable. So in a skewed variable, you have to summarize it in only in terms of medians, right? Median duration of days of ventilation in group A versus median ventilator days in group B. So statistically, to adjust for the various confounders, to get an adjusted value, it is very complex to do it in medians, whereas means are easy to adjust. So they wanted to convert this continuous variable into some form of categorical variable. So they, rather than just choosing a value arbitrarily, they just looked into the data and they have done this ROC to find out which number will be a better number for classification into two. That is where they have used ROC here. Nothing like an ROC what we use in diagnostic tests. I hope I have answered your query. If you're not happy, then we'll take it up later. Arul Nancy has asked a question. There should have been a subgroup analysis with only matched babies with respect to gestational age, birth weight, and diabetes between groups to rule out the effect of confounding. Arul Nancy, we don't do a subgroup analysis for all the factors which are different between the two groups. Right, because so a subgroup analysis can be, it always has to be decided a priori. That means before we start the study, we decide what are the subgroups that we are going to analyze. There has to be a scientific reason that, let's say here we can say they have taken less than 32 weeks as one group. We can say I will take less than 28 as one group and 28 to 32 as another group. The BPD rates are different between the two groups. Maybe the intervention works differently in these two groups, or for different NICUs, different kind of level 3 settings versus a level 2, something like that. So that can only be taken as a subgroup, not for the baseline variables which are different. It is not advisable. The more subgroup analysis you do, especially if you do what we call as a post hoc subgroup analysis, you are likely to get a p-value which is significant, which may be simply an alpha error. That happens just by chance. It is not at all advisable. Sir, I think Ashish Jain has asked a question. What determines the transportability in a study that is totally conducted in different country areas with letter heterogeneity? Can we see something in this article to look at the determinants? I think Saurabh sir and Dr. Veera had answered, discussed this in detail, Dr. Ashish. So I'm just moving ahead. Reshma had asked a question. Can we use non-parametric tests for analyzing non-normally distributed data instead of using ROC? I think this point was also just discussed. The difficulty was not in analysis, the difficulty was in adjusting for the confounders. beyond median. They can analyze two medians, but I am also not a big expert. This is what I understand. Maybe Saurabh sir can answer that later. The reason why they had, sir, can you answer that now, sir? Or why they had to convert the medians into categorical variables?
Oh, I'm also not sure. I think it's easier for clinicians. It's easier for clinicians to deal with categorical variables.
Yeah.
It's
Yeah.
easier to say long duration of ventilation versus short duration. What is the effect on the outcome, rather than a number? One thing we have to be a little careful about, what these authors have done is they have used their own data
Yeah.
to get the cutoff, right? ROC curve derived from their own data. And now they are using that cutoff on their own data again to do the logistic regression. Now, this creates a spurious association between that cutoff and the outcome. See, the cutoff has not come from a previous study or a known sort of way of dividing this thing. It is driven from their own data and then reused on their own data. So it will always tend to have a spuriously better association than what you see in real life. That's one thing that has to be kept in mind.
Thank you, sir. Reshma had asked another question. Kindly explain the term retrospective analysis of prospectively collected data in a cohort study. Is it so in all cohort studies? See, I think you have a little confusion there. That analysis, the collection of the data in a cohort is always prospective. When we mean prospective, we start from the exposure and move towards the outcome. That is what we mean by prospective. And in case control, it is the reverse, right? We start from the outcome and then move in the reverse direction to see the multiple exposures that could have happened. So whatever be the cohort, whether it is from a past data, present data, or we are going to do it in future, we start from, we assemble the groups, we start measuring it is based upon exposure. From there, we start moving in a prospective direction to measure the outcomes. That is why all the data collection and is only prospective in a cohort study. What we mean by retrospective cohort is that when are we assembling this cohort? If I'm starting this study today, one group of LISA versus one group of Ensure, observation study, and I'm going to collect data from now onwards, it is a prospective cohort. If I go back in time to 2010 to see that, okay, who received LISA and Ensure in 2010, but still assemble the cohorts in the past, and from I have to data collection has to happen in a prospective direction only. So this is what we call as a retrospective cohort. Sometimes there are some ambidirectional cohorts also. We can start in the past and move into the present and move towards the future also. These are various types of cohort studies. Tapas has asked a question, how do we perform matching in an observation study? Matching in general is what? When we know there some important parameters can be big confounders, and you don't have a way of eliminating those confounders also. You can't exclude them through an exclusion criteria. But still, and you believe that, and you don't have a larger number to believe that the data will get equally distributed between the two groups. In those situations, we go for what we as matching. Let's say birth weight. Can I just take a match a 1 kilogram baby of Ensure versus a 1 kilogram baby of LISA? But that is only based upon one or two pre-decided parameters, and we then do a matching. I have already discussed what are the situations in which you go for matching. There is no matching has been done here, but this is a huge data set. A reasonable adjustment would be automatically taken care in huge data sets. Prakash Shoni has asked a question. The study says protocol registration was not done, but ethical approval was taken. Difference between protocol registration and ethical approval. What is the difference? And do observation studies also mandate protocol registration? See, protocol registration is about registries. India has got a registry called Clinical Trials Registry of India. There are central registries in US, and registration actually happens after you take an ethical approval. The first step in any study, the study has to be approved by your institutional ethics committee. You make a plan, you take it to the ethics and just see whether it is okay. Ethical approvals are required even for observational study designs. Why? You're talking about sensitive data. The ethics will look into So what kind of data you are going to use, who has access to the data, so many things they will look into. So it is necessary to submit even observational studies. You need to get an ethical approval. The registry is about once you have got an ethical approval, once your protocol is finalized, it is all about transparency. You just say, I'm going to do this analysis, you are putting it into the public domain where everyone has access to that registry. They say so and so is going to do this trial, where all your definitions are very clear. What is your inclusion criteria? What is your exclusion criteria? What is your sample size? So that gives a lot of credibility to your study. But once you put it in public domain, you can't go back. That's where registries come in. And so these two are totally different things. It's a good idea to register these trials also. I think blinding we have discussed already. We'll discuss in the section. Three more questions only. Dr. Ram Kumar has asked, as it is a known fact that confounders are the biggest drawbacks of observation studies, kindly let us know what are the various methods by which the confounders can be minimized to the bare minimal levels in analyzing observational study data. This also we had a little bit of a discussion. If it is possible to exclude a confounder, if it is a small like in this study, they have taken chromosomal anomalies, congenital malformations. They could be a confounding variable for death. It is easy to, because those numbers are very, very small. We can exclude them easily. But what about a birth weight or a gestational age? Is it possible to exclude? It is not possible to exclude. If it is a smaller study with small numbers, we can go for matching, but it has its both advantages and disadvantages. The only other thing I know to avoid reasonably have the confounders equally distributed is about your numbers. You plan a larger trial where you believe that the numbers take care of distribution equally between the two groups. There are various methods of matching where we can put in various multiple, we can match for not only for one parameter like a propensity score and all. I'm not getting into that, but these are the simple steps we take in an observational trial to minimize the confounding effect. Murugesan has asked, Anita has asked, events happening after the exposure, can they be considered as confounders? Should they not be called as outcomes even though they are soft outcomes? I think Anita is asking about the need for a repeat dose of surfactant. They have adjusted for it when they have taken this outcome.
Can I just butt in?
Yes, sir, please.
Can I
Sir.
just butt in? Yeah, I think she's asked an extremely good question.
Yes, sir. Yes, sir.
Because this thing is very clear in a randomized control trial. So in a randomized control trial, anything that happens after the point of randomization is an outcome. It is not a baseline characteristic, so it cannot be a confounder. Whatever is happening after randomization is not a confounder. It is an outcome. But in an observational study, this is not clear because the patients have not been randomly allocated. So because they have not been randomly allocated, events occurring even after the so-called exposure are not baseline events. So could still be, events that are different between the two arms, which could independently affect the outcome. And they are not guaranteed to be equally distributed. In a randomized control trial, all events occurring after the point of randomization are guaranteed to be equally distributed, except for those which are influenced by your intervention. But that is not so in an observational study. So in an observational study, you could have events after the exposure, which could be confounders.
Thank you, sir. That's a learning for me as well, sir. Thank you, sir.
Mangala, can I point? Put my point towards two aspects: confounding and registration of the protocol a
Please,
priori.
yeah, please.
Confounding is inherent in any observational trial. So you have lots of softwares where matching can be done in a stringent way, but I'm talking from a perspective of a meta analyst. So if someone says confounding is low in an observational trial, I'll suspect that because confounding is inherent. In our software, you have the strongest packages to overcome confounding. In case control trials, for example, still it's inherent. If someone says confounding, when you come to the domain of confounding, they say low. As a reviewer, I'll say that is not possible. So confounding is inherent. Second is about registration of the trial a priori, an observational trial. Now, as per the ICMG criteria, you have to register a trial even if it is an observational trial. If you don't, then your trial will be rated down for risk of bias. Because if you don't have an a priori outcomes, then your trial is subject to selective reporting bias. So these two things are quite important, not for reporting, as I pointed out before, because my perspective is from being a meta-analyst. So confounding is always there. It can be moderate. It can never be low in an observational trial. Whatever software use, whatever you do, for selective reporting, you might be able to have a low risk of bias if you have a protocol that is a priori registered. And there are two points of view in that. This is always a point of discussion. I hope Saurabh sir and yourself can put some views into that. Some people say if they have reported all the outcomes, why should I downgrade for selective reporting? And there is another point of view where they say that you don't have an a priori protocol. So how I am sure that they have reported all the outcomes. So two things: confounding, it can never be low in an observational trial. Second, selective reporting, you can have a low risk of bias provided you have an a priori protocol. That's why I always advise my students that register your trial, even if it's observational, in a trial registry. I hope I am clear.
Thanks, Veera, for making a very strong point. So we should register observational trials as well. I have only two more questions, then I'll hand it over to Saurabh sir. I'll finish it off quickly. Poonam Singh has asked, is it possible that neonates receiving Ensure were sicker to begin with? That's why their outcomes were poorer compared to LISA. If this was true, then how it is possible for LISA exposed neonates to be of younger gestational age? The question is very valid. That is the problem in observational trials, right? So there could have been, that's what we call as a selection bias. So the babies in one arm could have been more sicker compared to the tough than other arm. There is no way only in an interventional trial like an RCT, we can ensure that babies of the same level of sickness have the equal chance of getting into both the limbs. So this is one of the major limitation. You are right to point out. That is why we say we have to always read the results with a pinch of salt. They can talk about association, observation studies, but they can't conclude causation. And just last, Dr. Ramkumar had just asked, to what extent observation study gives a good hypothesis which paves the pathway for intervention study? In the era and situation where there are lots of evidence for the LISA, what does the large observation studies at this stage give more weightage apart from hypothesis generation? It's a very good question, but this question was raised earlier by Veera, and I think excellently it was answered. What to say, the most crucial input was given from Saurabh sir. If you're not listened to it, see, even if there is a lot of information from randomized controlled trials, we know the answer to certain questions. Those are in a controlled environment. So it's always good to know, even after that, how it is happening in a real world. That's what we call the type 4 study, like for a drug study, right? What happens once it comes to the real world. So there is no harm. We are not doing any interventional trial. It is only a data we are collecting and analyzing from a database. So that will either strengthen or make us look back about whatever we have found from randomized control trials. Is it really the same result are we seeing in the real world? In that aspect, definitely we don't. You are very right to point out. Once you have answers from randomized control trials, we don't need observational trials for hypothesis generation, but they can be useful to understand how the answers we found in our cities work in a real world scenario. Sir, all the questions are finished, sir. So over to you, sir.
Oh, thank you, Dr. Mangala. And in fact, the last bit, the phase 4 thing, is much more true for harmful effects. Because for harm, your sample sizes in randomized control trials are never adequate for detecting harm. They're always underpowered. So sometimes the harmful effects of drugs actually come up in phase 4 studies, not so much the beneficial effects are usually already proven in RCTs. I would now hand over to Dr. Amit Upadhyay, who's the secretary of NNF, for his concluding remarks and for inviting you all for the next journal club. Over to you, Dr. Amit. Dr. Amit, are you here? Okay. So thank you all very much for having participated so actively in this journal club, and we hope to see you again next time. Our National Neonatology Forum journal clubs are held on the last Thursday at 8 p.m. of every month. So we've kept that fixed, and we are also going to keep the link for joining fixed so that it's the same every time. And each time we're going to take up a slightly different study design. The first time it was an RCT. This time it is an observational study. Maybe we may take up a diagnostic study and discuss about sensitivity, specificity, and so on, or a meta-analysis or something. So each time it will be something different, and then we will repeat the cycle. So to all of you, thank you very much for having participated so actively, and wish you a very good night and sleep well. Okay, bye-bye. With that, we bring this session to a close. Thank you very much.